my name is Nichole Choate. I am a DNP student here at Maryville University. The title of my DNP scholarly project is Hypertension Management Using Non-Pharmacological Lifestyle Modifications. The committee members for my scholarly project consist of my chair, Dr. Jean Gordon, and the second reader, Dr. Rita Wunderlich, and the community member, which is Dr. Patience McCoy. Hypertension is a chronic condition which is a worldwide health concern. When poorly controlled, it can lead to development of comorbidities and an increased rate of mortality among patients. Hypertension is commonly referred to as the silent killer because some patients are asymptomatic and are unaware of their condition. Interventions are focused on risk factor modification through healthy lifestyle practices to reduce or delay further disease development and mortality. Close monitoring and control of hypertension is essential for patients to decrease the further development of chronic health conditions such as cardiovascular disease. Hypertension is considered the single most important contributor to patient mortality and morbidity, accounting for more than 7.5 million deaths worldwide annually. The purpose of this DNP project was to implement an evidence-based hypertension guideline endorsed by the American Heart Association that focused on the improvement and self-management of hypertension among patients who were diagnosed with hypertension and congestive heart failure. The guideline focused on improving management of hypertension using non-pharmacological self-management recommendations for patients at the cardiology clinic who were diagnosed with essential or primary hypertension and congestive heart failure. In 2017, the ACC and American Heart Association developed a multidisciplinary task force that released guidelines to address the prevention, management, and treatment of hypertension. These guidelines provide a framework for healthcare providers to use in treating patients with hypertension. The AHA recommended for patients to participate in non-pharmacological lifestyle modifications that consisted of consuming a heart-healthy diet that included the reduction of sodium consumption for the dietary approaches to stop hypertension, also known as the DASH diet, weight management or reduction to stay within the recommended healthy BMI range based on their height and weight, encouragement to participate in 90 to 150 minutes of aerobic exercise weekly, and to limit their daily alcohol consumption to 1 drink for women and 2 drinks for men to improve their blood pressure management. Prior to this project, the cardiology clinic had no consistent process in place to educate patients about hypertension, which varied based on the provider. By providing educational resources to patients, encouraged active participation in their treatment plan and promotion of adherence to lifestyle modifications. These will also improve the management of their hypertension and prevent further disease development. Patient education is a key component of hypertension management. The AHA's guideline was chosen for implementation due to the high regard it holds in the field of cardiology through its support of the use of evidence-based practice guidelines. The overall goal to inspire practice change in the current process of providing educational information to patients within the cardiology clinic to improve their hypertension self-management. The effectiveness of the project was based upon the systolic blood pressure and body mass index readings of patients pre- and post-educational intervention. The aims of this project is to increase patient knowledge of hypertension, increase patient participation in their treatment plan, and to decrease the systolic blood pressure by 4 to 11 millimeters mercury and BMI measurements of patients through the implementation of lifestyle modifications as supported through patient education. Uncontrolled hypertension is the leading cause of cardiovascular disease, cerebrovascular accidents, and renal disease, with hypertension accounting for 13.5% of annual deaths worldwide. It is currently estimated that hypertension affects 25% of the world's population. The number of patients diagnosed with hypertension is continuing to increase and is anticipated that by year 2025, approximately 1 out of every 3 people will have been diagnosed with hypertension. The World Health Organization estimated that 46% of adults with hypertension are unaware that they have the condition, causing an even greater need for health providers to offer patients educational interventions. The goals set forth by the AHA focused on improving the cardiovascular health of all Americans by issuing a list of 7 influencing factors that affect the management of cardiovascular disease. 4 of the 7 factors focused on modifying lifestyle behaviors such as smoking cessation, healthy diet consumption, daily physical activity, and maintaining a healthy weight with a BMI within the recommended range. The 3 remaining factors included biometric measurements of blood pressure, cholesterol, and blood glucose readings. Successful management of chronic conditions requires a holistic approach to treatment where patients need to make healthy lifestyle choices in addition to the use of medication therapy. Lifestyle modifications are recommended to be implemented in addition to the use of medication therapy to improve the management of the hypertension. Providers should strive to address any lack of resources that cause patients to be unsuccessful in the management of their hypertension and to encourage patients to participate in programs such as guided walking that is shown to be effective in reducing systolic and diastolic blood pressures. Patients who monitor their hypertension closely at home by performing regular blood pressure monitoring were also noted to be compliant with follow-up care as well with their provider. Patient education is a key component that influences their level of adherence and compliance to treatment regimens, which is also considered one of the domains of nursing that guides nursing practice. The modification of lifestyle practices that includes making healthy choices occurs when patients feel supported and encouraged in their treatment, in addition to having an increased understanding of their condition. Through active involvement in their treatment plan and adherence to lifestyle modifications, patients will improve the management of their hypertension and prevent further disease development. APRNs play a pivotal role in the identification of patients with uncontrolled hypertension, and they also have the ability to quickly prescribe a treatment regimen to prevent disease complications. In addition to pharmacological approach to treatment, they can incorporate the use of non-pharmacological approaches such as weight loss in patients who are overweight, the restriction of dietary sodium intake, the reduction of alcohol consumption, and active participation in exercise program geared towards each patient's physical abilities. The APRN is able to set a realistic treatment goal and that assists the patient with locating any necessary resources as well for them to be successful. The theory that was used for the scholarly project was the health belief model by Marshall Becker. The model was based upon the belief that people will change their current health practices and behavior due to the potential threat of health complications. The threat of their worsening illness or the potential to become ill sparks motivation in people to start practicing health-promoting behaviors. This project was focused on improving the health of patients diagnosed with hypertension and congestive heart failure by implementing the use of the AHA's Life Simple 7 lifestyle changes. The lifestyle changes aim at improving cardiovascular health by better blood pressure management, cholesterol control, blood glucose reduction, participating in daily exercise, consuming a heart-healthy diet, losing weight, and quitting smoking. The framework around which this theory was developed was based upon the health-related actions and beliefs of patients. The patients must have the motivation to make healthy lifestyle changes due to the perceiving an illness or threat as possible, and that it may affect them severely while viewing the changes as beneficial and worth the cost. Patients with hypertension and CHF must realize that their health conditions may worsen and that they can become severely ill if they do not make a change. Although patients may perceive the threat of their condition worsening, if they do not follow the recommendation and make the lifestyle changes, this will also serve as a motion to make the changes. Patients who are more compliant with treatment regimens to control their hypertension have a higher level of perceived benefits to treatment. The design of the project was a quantitative exploratory design consisting of a retrospective chart review to collect the necessary data through the review of electronic medical records. The AHA developed and endorses the use of their guidelines, which provides patients with lifestyle recommendations focused on ways to improve self-management of their hypertension and overall cardiovascular health. The patients were verbally educated on the importance of applying the AHA's Life Simple 7 guidelines into their daily routines by the providers. Patients were also given a brochure that contained detailed recommendations to better control their hypertension. The clinical staff documented the height and weight of every patient, allowing the EMR to calculate a BMI measurement for every patient. They also documented a blood pressure measurement for each patient as well. The project design contains the following inclusion and exclusion criteria. The inclusion for the participants' EMRs was based upon their age, diagnosis, date of pre- and post-evaluation, and documentation of pre- and post-intervention systolic blood pressure and BMI measurements. Next, the exclusion criteria was based upon their age, date of pre- and post-evaluation, diagnosis, participation in cardiac rehab, and documentation of pre- and post-systolic blood pressure and BMI measurements. Participants from the cardiology clinic were not actively recruited for participation in the study. This scholarly project was a retrospective chart review. The process of obtaining participants was based upon the inclusion and exclusion criteria, which was used to identify potential participants. A list of patients who were seen at the cardiology clinic within the designated time frame was provided to the researcher by the healthcare system based upon the specified criteria. Prior to obtaining a list of the participants, the project was approved by Maryville's IRB, the healthcare system's manager of risk and regulatory compliance, and the cardiologist at the cardiology clinic. This scholarly project was conducted in a rural cardiology clinic, which is part of a community-based healthcare system located in the Midwest region of the United States. Clinical staff members at the cardiology clinic consist of 2 members, an MD and APRN, and the clinical staff, an RN, LPN, and RMA. The sample participants consist of patients who were ages 40 to 89 years in age, the diagnosis of hypertension, and congestive heart failure from the targeted cardiology clinic within the healthcare system based on their ICD code. The sample population produced 45 participants. Of those, only 24 participants met the inclusion criteria. The study structure included a quantitative exploratory study design that incorporated a retrospective chart review. The results were evaluated by comparing the systolic blood pressure and BMI measurements of the study participants' pre-educational intervention to the post-educational intervention. The use of descriptive statistics and research allows researchers to communicate, describe, and summarize their data. Descriptive statistics were utilized to analyze the demographic data of the study participants. The sample consists of 75.5% or 34 male patients and 24.4 or 11 female patients. The ethnic background of the sample size included 95.5% or 43 participants were Caucasian and 4.4% or 2 participants were Hispanic. To ensure the safety of the study participants, several measures were taken throughout the project to prevent the breach of confidentiality, which included the researcher completing the CT training and the researcher site HIPAA training as well. The project's participants and healthcare facility were generally described. All patient identifiers were removed. The hospital's manager of risk and regulatory compliance provided the researcher with a written list of patients who participated. This list was stored in a secured and locked area. The researcher will destroy all information 3 years after the completion of the project. The participants' systolic blood pressure readings and BMIs were extracted from the charts and placed into the data collection sheet and then inputted into Microsoft Excel. A data collection sheet was created for this project using an extensive literature review prior to the IRB approval and data retrieval. The information gathered from the EMRs was de-identified and transcribed into the data collection sheet. The data collection sheet listed the participants based upon a randomly assigned number. The participants' systolic blood pressure and BMI measurements prior to the completion of the intervention, and if no follow-up evaluation was conducted. The patients who did not follow up during the specified time were coded as an X and an XX if they had expired. The results included in the Excel document were then transcribed into SPSS software for comparison with the assistance of the statistician. The pre- and post-systolic blood pressures and BMI measurements were analyzed using a pair-T test. A pair-T test was initially chosen to be conducted based on the assumption of the dependent variables, systolic blood pressure and BMI measurements were normally distributed but for both pre- and post measurements. The tests for normality were conducted, but due to the presence of outliers, the assumption of normality was violated. Since there were violations to the assumption of normality, a non-parametric Wilcoxon-Stein ranks test was conducted. This test was used to determine the statistical significance of the difference in systolic blood pressure and BMI measurements with the use of the American Heart Association's Life Symbol 7 hypertension guidelines compared to the pre-intervention baseline measurements. This test indicated that there was not a statistical significance in the results of to reject the null hypothesis that the pre and post measurements were the same. The test resulted in a Z statistic of negative 0.061 with an associated p-value of 0.951. For both the dependent variable systolic blood pressure and BMI measurements of the study participants, the results indicated that there was no statistical improvement in the systolic blood pressure and BMI measurements of the study participants after the implementation of the hypertension education protocol. A visual comparison of the participants' baseline systolic blood pressure measurements compared to the post-intervention measurements and the degree of fluctuation between each participant's measurements is included in the slide above. Additionally, a visual representation was also created to display the little variance in participants' BMI measurements from their baseline measurements to their post-intervention measurements that appeared to have no change in measurements overall. There were limitations observed in the project. The limited time frame of this project did impact and limit the number of study participants, since the patients had to be reevaluated at the cardiology clinic after undergoing the educational intervention during the specified time frame on the assumption of staff availability. Since the study occurred during the holidays, providers took vacation time during the designated time frame, which limited the availability of appointments at the cardiology clinic. The limited availability of appointments did negatively impact the evaluation of some patients, causing them to be seen outside of the designated time frame, which excluded them from the project. A second limitation was that the study was conducted during a pandemic where social distancing and masking mandates were enforced by the healthcare system. The requirement of the patients to follow the strict guidelines resulted in patients choosing to conduct a virtual visit in place of a face-to-face encounter with their providers. This limitation did negatively impact the project by a reduction in the number of available patients to be evaluated at the cardiology clinic due to them opting for virtual care visits. The occurrence of the pandemic did contribute to the project's small sample size. The study sample lacked ethnic and cultural diversity due to the cardiology practices rural setting in the Midwest United States. The identification of the external factors that negatively impacted this project is important to acknowledge because their identification can be modified for future research. One way that the project's limitations were minimized for this project was by dealing with the implementation of the project by 1 month due to the multiple staff members taking summer vacations due to the initial start dates. Postponing the start date by the researcher where staff members postponing the start date of the project allowed more involvement of staff during the development process who attended an educational session conducted by the researcher where staff provided feedback. Although this did allow for staff involvement in the implementation of the project, it cannot minimize the occurrence of national holidays and anticipated absence of staff during the holidays. Non-pharmacological hypertension management strategies are recognized as an essential component in the treatment approach to preventing and improving the management of hypertension. This study aimed to evaluate the effectiveness of an evidence-based hypertension guideline in treating cardiac patients diagnosed with CHF and hypertension. The ability of the patients to better manage their hypertension using non-pharmacological recommendations did not show a statistical improvement from period post-implementation consistent with the null hypothesis. Prior research studies have shown an improvement in the management of hypertension that can be achieved by practicing lifestyle modifications regularly. It is essential to note that the study's timing, timeframe, sample size, and demographic location of the study all factored into the differences between the observed and expected outcomes of the study. The study's limited timeframe and rural location resulted in limited ethnic diversity that contributed to a small sample size. Future studies should aim to be implemented for a longer duration of time and to include multiple cardiology clinics for more accurate result findings. Another potential cause that impacted the study was the occurrence of the COVID-19 pandemic and the safety requirements such as masking and social distancing that were enforced during the study's timeframe. The strict mandates issued during the timeframe prevented patients from physically presenting to the cardiac clinic for visits and using virtual visits for their care. Successful implementation of the lifestyle modifications may reduce the need for avoidable ER visits and associated financial burden associated with the hypertension. Kirkland estimated that hypertension patients had approximately $2,000 higher annual healthcare expenditures compared to patients without hypertension. They also estimated that healthcare costs associated with hypertension in the United States were $131 billion annually. This creates a large financial burden for the healthcare system. The CDC recommended that patients to start early by preventing and managing hypertension through cost-effective solutions such as lifestyle modifications that prevent further disease development that may be costly in the future. In 2018, in the United States, there was a total of 33.6 million physician office visits and 1.1 million ER visits where patients were seen and evaluated with the primary diagnosis of hypertension. This project demonstrates the need for additional educational programs that improve hypertension management in rural communities. Through the support of healthcare leaders, the importance of hypertension management and prevention and further disease development can influence policymakers to support healthcare promoting bills that provide more resources for healthcare education. Healthcare promotion is the fundamental principle of nursing practice. Providing safe and high-quality patient care is a priority among healthcare systems. The project's aim was to provide a safe and high-quality patient care to support hypertension management. Implementing evidence-based practice guidelines into the current practice gives providers the tools that they can be used as resources for patient education to promote adherence to treatment regimens. Hypertension treatment guidelines serve providers as treatment plans to ensure consistency of provider care. Through educational counseling, patients were encouraged to take a more active role in the management of their hypertension. Nursing strives to provide a high-quality patient care through the implementation of evidence-based nursing practices that aim to improve patient outcomes. They use their knowledge obtained from the formal education and personal experience to provide a holistic approach when addressing the needs of their patients. This project promotes the importance of patient education and active participation in the treatment plan to manage their hypertension successfully. The use of evidence-based practice guidelines standardizes the educating of patients. This ensures accuracy and consistency in the educational material provided to patients to assist them with successfully managing their hypertension. A standardization in the process of educating patients about hypertension throughout the healthcare system would be essential to ensure all patients receive the necessary educational information to manage their disease successfully and prevent further disease development. So in conclusion, the recommendations for current practice are to ensure consistency in the educational material distributed to patients across the healthcare system with the healthcare system's intranet. The healthcare system can closely regulate the process of updating and monitoring educational information's accuracy before patient distribution. This can improve the frequency with which educational resources are used for patient teaching during their appointments at the clinics. The project sought to provide statistical evidence for an improvement in the medical management of hypertension using non-pharmacological lifestyle modifications. The findings suggest that there is no statistical significant improvement in the management of hypertension to support a change in the current practice at the cardiology clinic. Future studies are conducted with a longer time frame, larger sample size, and without the occurrence of a pandemic or national holiday will help support the effectiveness of implementing the use of hypertension guidelines into the current practice. This project identified the inconsistencies in providing hypertension education to patients with the various resources currently used in the cardiology clinic. The informational posters displayed in the patient examination room will serve as an educational reminder to assist providers with explaining the ways that the patients can better self-manage their hypertension. The study findings will be disseminated into the quality department through the healthcare system. The results will be shared via email with the hospital's manager of risk and regulatory compliance, as previously agreed upon by the researcher in the healthcare system. The impact that this DMP program has had on my career was positive. I am assessing and analyzing processes which occur at the cardiology clinic to look at the ways to increase efficiency and ensure that that is truly the best practice. I no longer settle for the response, "We have always done it like this." When asking others, I now feel confident in my ability to research the necessary information and apply the recommendations into practice, or otherwise practice translational research. Does anyone have any questions regarding my scholarly project regarding hypertension management using non-pharmacological lifestyle modifications? And here's a list of references which are used for my presentation. And here is another list as well, continue. And I thank you for your time today.